This is the Emergency Medical Minute, sponsored by Mile High Ambulance. The Emergency Medical Minute is excited to announce that we are now offering AMA, PRA, Category 1 credits via online course modules. To access these and for more information, visit our website at www.emergencymedicalminute.com/CME-courses, or simply click on the link in our show notes and create an account.
So I'm going to take a minute to talk a little bit about antibiotic choices in pneumonia, specifically community-acquired pneumonia. I'm going to be drawing upon the 2019 ATS, so American Thoracic Society, and the IDSA, which is the Infectious Disease Society of America, guidelines, which are generally considered the most relevant and up-to-date guidelines in terms of how we approach pneumonia patient antibiotic choice. So a couple of things. In general, we put patients into two broad categories for community-acquired pneumonia patients. Patients that meet sort of outpatient criteria, and sometimes you use clinical gestalt, sometimes you use decision algorithms like port score, but for our purposes here, we're going to just say we have a patient who's an outpatient candidate for pneumonia versus a patient that's sort of sick enough to be hospitalized. So in terms of patients that are outpatient candidates, the main distinction we use to determine what type of antibiotics that patient requires ends up being their underlying comorbidities. All right. So in a patient that's otherwise relatively healthy with no significant comorbidities, and I'll talk about them, the ATS and IDSA guidelines suggest one of three antibiotics, and it's high-dose amoxicillin, doxycycline, and sometimes a macrolide like azithromycin. And they're generally all considered adequate and appropriate. In patients that have in patients that have comorbidities, and that's defined here as people that have any chronic disease like chronic lung disease, chronic heart disease, chronic kidney disease, known immunocompromised state, or like diabetes. They include alcoholism and asplenia here as well. Asplenia would be patients that perhaps had a spleen removed from trauma, sickle cell patients who are technically autosplenectomized, and they're at risk for encapsulated organisms, or sometimes as part of like lymphoma treatment, splenectomy is done. So the patients that have those types of comorbidities, the sort of treatment regimens have changed significantly, and in general it's augmentin or cephalosporin. In our setting here, most commonly you'll see providers using Ceftin and either doxycycline or macrolide. Notably, they still have respiratory quinolones, things like levaquin, as alternatives, but increasingly, I think most of the providers in our setting are recognizing as long as there's therapeutic alternatives, we avoid sort of the complication. So it's dual treatment, dual antibiotics. Moving to the inpatient side, where patients are sick enough to be hospitalized, the reason I circled it here is that there are certain patients that are at higher risk for multi-drug resistant organisms, and that causes an expansion of antibiotic coverage if the patients are sick enough. It used to be if the patients were potentially exposed to multi-drug resistant things or organisms, so patients that had a hospitalization even within 90 days, patients that are residents of long-term care facilities like nursing homes or SNFs, even assisted care, people that are in the dialysis center, that those were all sort of risk factors. Increasingly, it was recognized in studies that those patients, when they were given extremely broad antibiotics, potentially did worse because they were overtreated in terms of the antibiotic spectrum that was necessary to treat their disease. So the point here being, when patients are admitted, the standard treatment, and that's what we see here all the time, is macrolide like azithromycin and a third generation cephalosporin. The things that are sort of multi-drug resistant or atypical pathogens, generally the consideration there is whether or not you add vancomycin to their regimen and whether or not you add anti-pseudomonal coverage. And it ends up, if you look through this algorithm, basically, if they're at risk, then they've had a prior MRSA isolate from their sputum or blood culture from pneumonia or pseudomonas. So if they're at that high enough risk that they've had positive cultures in the past, then they get broader coverage. And then importantly, even if they have these risk factors like recent hospitalization, IV antibiotics, local risk factors, only when they're sick enough, so severe inpatient pneumonia, so think ICU patients, do you add coverage for vanco or vanco for MRSA, and then anti-pseudomonal coverage, typically with zocin or cefepime. So I circled these things up here because I think they really sort of give you a sense of, if patients are outpatient candidates, if they have significant comorbidities, then they're treated different. And if they're inpatient, only if they're extremely sick and they have risk factors for multi-drug resistant organisms or MRSA or pseudomonas, then you give them the advanced antibiotics beyond sort of the macrolide and the cephalosporin. All right? So, I think this sort of underscores sort of what you see empirically. This should seem really intuitive to the outpatient pneumonia regimens and the inpatient pneumonia or the ICU regimens, but it's sort of codified here in the ATS and IDSA guidelines. So feel free to look at that to sort of solidify that. All right, does that all sort of make sense? Yeah, okay. Sure, guys.
The Emergency Medical Minute would like to thank our sponsor, Swedish Medical Center, for helping fund our nonprofit organization and make this podcast possible. Donations are essential to our organization to cover operational costs and fund the creation of our online courses offering AMA PRA Category 1 credits. So if you enjoy our show, and if you're able to make a one-time or recurring donation towards our organization, any amount is helpful. Please click the link in our show notes to make a donation. Thank you for listening.